I have no conflicts that are relevant to the data that I'm going to show you. And as has been mentioned, for a long time I was at the University of Edinburgh. I recently took up an additional leadership position at Newcastle University, so I currently split my time between the two. And at Edinburgh, for many years, what we were interested in is the role of glucocorticoids in cardiovascular disease. So, of course, an obvious starting point is to ask about the hypothalamic pituitary adrenal axis and its potential role in cardiovascular disease. And one would think that by analogy with glucocorticoid excess in Cushing syndrome, causing obesity, hypertension, and indeed accelerated cardiovascular disease, it was possible that more subtle abnormalities of glucocorticoid action in the general population could account for the clustering of cardiovascular risk factors and indeed risks of cardiovascular disease. And indeed, we've gone on and shown, as others have, through cross-sectional data and through prospective studies more recently, and most recently through genetic studies, that there is now strong evidence that activation of the HPA axis is a primary driver for later cardiovascular disease. That can be exacerbated by early life events and early life stressors causing low birth weight in addition. In addition, we've been interested, as others have, in what might happen in glucocorticoid deficiency. And of course, there are manifestations of Addison's disease and of congenital adrenal hyperplasia and other causes of glucocorticoid deficiency, which might be relevant, again, on a population basis or in unusual circumstances, such as in critical illness or in post-traumatic stress disorder. That's been less of a focus of our work. So that's been an interesting seam of research describing changes in the HPA axis, and one hears a lot about it at meetings and in the literature. But I guess I'd put it to you that it doesn't make that much difference to our clinical practice, because although this may have prognostic value, it doesn't actually have any therapeutic value, because we wouldn't want to intervene to inhibit the HPA axis and its performance during stress. And I suppose that's the primary motivation for a lot of our work, having then turned to the dissection, the opening up of the black box of the factors which determine tissue sensitivity to glucocorticoids. Because there might be subtle individual differences between tissues, and there might be opportunities for therapeutic manipulation as well as mechanistic understanding. And I think that this field has made good progress over the last couple of decades in identifying therapeutic opportunities. The leading light in this field would be the discovery of 11-beta-HSD1 as an amplifier of glucocorticoid action in metabolic tissues, including adipose and liver, and also in the brain. And many of you will know that 11-beta-HSD1 inhibitors got as far as phase 2 trials in patients with type 2 diabetes and were effective, but the magnitude of the effect on blood glucose was insufficient to lead to their subsequent commercial development. You may not know that 11-beta-HSD1 inhibitors are still in clinical trials for dementia, with the outcome of those studies coming along next year. Moving on from that observation, which many of you will know about, you may not be so familiar with the established role now of other enzymes which modify glucocorticoid action in tissues, such as the 5-alpha reductases, and recent data would suggest that manipulating 5-alpha reductase has an effect on the risk of type 2 diabetes, for example, in patients with prostate disease, or new enzymes, new kids on the block, such as CBR1, which generates a more potent mineralocorticoid metabolite of glucocorticoids and might be important in obesity-associated hypertension. And then, beyond those metabolic pathways influencing tissue steroids, we now know about the role of protein binding. So this cartoon is supposed to illustrate corticosteroid binding globulin, or CBG, which is cleaved at sites of inflammation by neutrophil elastase, hypothetically to release cortisol to those sites of local inflammation. And motivated by some of the genetic observations about variations in CBG and its effects on glucocorticoid signaling, we're now exploring that mechanism as an additional factor. So that's the background. But the mechanism I wanted to talk about today relates to another determinant of the dynamic control of tissue glucocorticoids, which is the role of the ATP binding cassette transporters, or ABC transporters. There are about 50 of these. They've attracted most attention as drug resistance genes and transporters over the years. But what I'll show you is that they may have a physiological role in glucocorticoid action, and crucially that might provide new therapeutic opportunities. So our studies of ABC transporters were really inspired originally by Ron DeClute's work, and Ron, with Onno Meyer and other colleagues, documented that one particular ABC transporter, ABCB1, which is also called P-glycoprotein or MDR1, is present on the blood-brain barrier where it exports cortisol, but not any other steroid, from the brain. So that may limit the negative feedback signal and the actions of glucocorticoids in the brain. Now, the interesting thing about that in particular is that ABCB1 does not excrete or does not transport corticosterone, the alternative glucocorticoid. And you might think that that's not really particularly relevant. You probably know that corticosterone is considered as the major glucocorticoid in rats and mice because they don't express 17-hydroxylase from CYP17 in their adrenals, so they don't make cortisol. And you might think this only matters in rats and mice. But in fact, corticosterone is about 5 or even as much as 10% of your glucocorticoid pool in your plasma at present. And by sampling CSF, colleagues of mine were able to show that in the brain, corticosterone is about 30%, a substantial proportion of the glucocorticoid pool, presumably because the cortisol is exported by this transporter. So what that means is that that transporter is determining the brain being more sensitive to corticosterone, relatively speaking, than to cortisol. And then the question arises, well, what happens in other tissues, and tissues that might be relevant, for example, to cardiometabolic risk? And so we were inspired to go about looking for that, and we were stimulated by some additional data that we were collecting a few years ago. We were interested in the dynamic turnover of glucocorticoids within tissues. And I'll just show you 2 experiments that were an inspiration. One on the left is that this is a mouse brain using mass spectrometry tissue imaging to measure steroid concentrations in each of these pixels and doing a manipulation, in this case inhibition of 11-beta-HSD1, that shows you get very rapid changes in steroid concentration, in glucocorticoid concentration, over just an hour. So that suggests the steroid pool is turning over very quickly in the brain. But in the adipose tissue, we did an experiment where we infused in a labeled deuterated cortisol, which we could distinguish from endogenous steroid. And we infused this into healthy women in advance of their surgery for benign conditions, otherwise healthy women. And then we obtained adipose about 5 hours after infusion of the tracer and measured how much tracer had got its way into the adipose pool. And the answer is not very much. So this is the D4 cortisol in relation to plasma cortisol, endogenous cortisol, but only about half as much enrichment occurred over 5 hours in the adipose, indicating that the adipose has a very slow turnover, unlike the brain and actually unlike the liver in some other data. So why might that be? And might it be because there's different transporters allowing more rapid turnover in some tissues than others? So we then looked in human adipose at the distribution of ABC transporters. And this is data extracted from a microarray from healthy human adipose tissue. And the first observation is that ABCB1, the cortisol exporter, is not expressed to any degree in human adipose tissue. So it's unlike the brain, it's not exporting cortisol. However, another transporter, ABCC1, which the literature told us is able to export corticosterone, but not cortisol, that is very highly expressed. And we confirmed that ABCC1 is the major transporter that's known to transport steroids. These are the ones that we know transport steroids. It's the major transporter in adipose tissue. It's slightly dysregulated in obesity. I won't say more about that. And it's selectively expressed ahead of ABCB1 in these SGBS adipocytes, so we could use those as a model for human adipocytes. Interestingly, in mice, but not in horses, they don't bother to reduce their expression of ABCB1 in adipose tissue. Of course, they only have corticosterone, so arguably they don't need to have any influence over changes in cortisol access to adipose tissue. So we then looked at SGBS adipocytes and we tested whether this ABCC1 was having a functionally important role in exporting corticosterone or cortisol. And we used 2 inhibitors here, a Merck compound and probenecid, to inhibit ABCC1 and look at the accumulation of tritiated steroid within the cell. And you can see the inhibitors don't affect cortisol, but they cause an accumulation of corticosterone within the cell, consistent with ABCC1 exporting corticosterone. And then we could image that using CARS microscopy. This relies upon using laser light to get a resonance from a carbon-hydrogen bond and a different resonance from a carbon-deuterium bond. So when you put the deuterated steroid into this preparation, you can get a signal back that you can actually image the steroid concentration in the cells. And what you see here is the addition of the Merck compound and monitoring of the yellow signal from the corticosterone administration that's potentiated by the Merck compound. So that's just to visualize this same effect. And then we looked at gene transcription, and I won't dwell on these data, but essentially what we showed was that by inhibiting ABCC1, we would potentiate gene transcription induced by corticosterone, but not by cortisol. That selectivity of ABCC1 ahead of ABCB1, and therefore the possibility of differential sensitivity to corticosterone versus cortisol, is also present in other important tissues, including the muscle, skeletal muscle here, and in bone. These are bone cells expressing ABCC1, but not ABCB1. And indeed, just like in the adipocytes, when we take the bone cells and we inhibit ABCC1 with probenecid, we potentiate the response to corticosterone in terms of, this time, osteocalcin transcripts, and we have no effect on cortisol. So if you're struggling to put all those data together, let me help you with this cartoon. What I'm saying is that in the brain, ABCB1 would selectively export cortisol, leaving the brain disproportionately sensitive to corticosterone. But in the periphery, because of the absence of ABCB1 and the presence of ABCC1, we have a different pattern, where actually it's corticosterone that's exported and it's cortisol that would be disproportionately active. That's the hypothesis. Now, we then went about trying to test that in mice, and so we did that in two different mouse experiments, one pharmacological and one genetic. So here is an ABCC1 knockout mouse against an FEB background, and here's probenecid administration to C57 black 6 wild-type mice. And in both cases, we, as it were, humanized the mice by taking the adrenals out and then infusing in a mixture of cortisol and corticosterone. And what we showed was that in both circumstances, if you remove or inhibit ABCC1, you cause accumulation of corticosterone within the adipose tissue, but you have no effect on cortisol. And so the ratio is changed. And that's associated with changes in transcript, which, again, I won't dwell on, but essentially this is the potentiation of transcript induction in adipose tissue that we see by adding probenecid. Then the question is, well, that's all very well in mice, a poor model for any aspect of cortisol biology, because they don't usually have cortisol. What about humans? So to test in humans whether adipose is differentially sensitive to corticosterone or cortisol, we did this experiment. So we took patients with Addison's disease, because they would have a zero baseline with no glucocorticoid, and then we infused them with either cortisol or corticosterone at these ramped concentrations, and the intention was to achieve the same concentrations of both steroids. Now, in fact, by complete accident, we achieved a lower concentration of corticosterone than we did cortisol. But that was a happy accident, because in these Addisonian patients, the suppression of ACTH that we achieved was the same. In other words, these are equipotent concentrations for suppression of ACTH. So you'll note that ACTH seems rather more sensitive to corticosterone than it is to cortisol. However, when we took adipose biopsies at the end of these tracer infusions, steroid infusions, what we found was that cortisol had a much greater effect in inducing period 1 expression than did corticosterone. So the adipose was differentially more sensitive, while the brain was more sensitive to cortisol, while the brain was more sensitive, or the HP axis negative feedback was more sensitive to corticosterone. You might then start to wonder, well, what other evidence would support this being of significance in humans? This might be just pharmacology, you could say. Does it actually reflect what's happening in terms of endogenous activity of corticosterone and cortisol on the endogenous receptors? And that's a really tricky thing to test, actually. And one of the ways that we've addressed that in the past has been to try to measure displacement of ligands from the corticosteroid receptors. So by administering a mineralocorticoid receptor antagonist or a glucocorticoid receptor antagonist, in principle, you can measure the displacement of ligand from that receptor, and that might be an indication of how much the receptors are occupied by different steroids. And you might be thinking, how on earth are you going to do that? Well, we've done it in humans previously, because one of the things that we've done in our group over the years a lot is to cannulate specific veins draining individual tissues in order to look at steroid action within those tissues. And here's an example. So it doesn't really matter that this is the heart for the purpose of this talk, but this is cannulating the coronary sinus in order to measure arteriovenous differences across the myocardium. And what we did was to administer canrenoate, which is the active component of spironolactone. We gave it intravenously and achieved these drug concentrations. And then we measured the release into the coronary sinus of cortisol, and in this case, aldosterone. And what I'm showing you is just that by giving the MR antagonist, we can measure displacement of cortisol that is transient, whereas there wasn't displacement of aldosterone. This is an indication, by the way, that the heart mineralocorticoid receptor is occupied by cortisol and not by aldosterone. That's a different talk. So, we now want to see whether receptors in the adipose tissue are occupied by cortisol or by corticosterone, given that we think that there's differential pumping of the two. And we think that ABCC1 might be preventing corticosterone from being active in peripheral tissues. So we used a similar protocol. We brought people in, we cannulated a vein draining the skeletal muscle of their forearm, a vein draining their adipose tissue, and we administered a mineralocorticoid receptor antagonist and then added, sorry you can't see this very well, but added a glucocorticoid receptor antagonist to see what displacement occurred. Now the results are complex, and I'll draw your eye to the right thing in a moment, but let me just orientate you. So this is, in each of these panels, the first measurements are at baseline. This is after the MR antagonist, and then this is after the addition of a GR antagonist. The top line is for cortisol in blue, and the bottom line is for corticosterone in red. On the right is skeletal muscle, on the left is adipose tissue. And the intervention here has been to compare placebo with probenecid administration. And what I want to draw your eye to, actually, is just the adipose data for the moment, which shows release of cortisol from the adipose tissue, which tends to fall during the day. That's because of changes in circulating cortisol during this experiment. But note that probenecid has no effect. Whereas for corticosterone, there's this effect of probenecid to enhance the release, the displacement of corticosterone from the adipose tissue. So this is the evidence, such as it is, and these are difficult experiments, but this is the evidence that the receptors in adipose tissue are being occupied more so by corticosterone than by cortisol if you inhibit ABCC1. It's the evidence that ABCC1 protects those receptors from corticosterone. Okay. That's all very sort of fancy physiology, difficult studies, hard interpretation, quite complicated. Why would you care? And why, in particular, if you're a pediatric endocrinologist, should you really care? So I'm going to lead you through now three scenarios where I think this could be clinically important. Broadly speaking, they get more interesting as we go through, so wait for the punchline at the end if you're getting bored. So the first one is that actually this mechanism could be important in understanding the associations of HPA axis activation with metabolic syndrome. I want you to imagine what would happen if you had changes in CYP17 or 17-hydroxylase activity. Let's imagine that enzyme activity was subtly increased. You would have a fall in corticosterone relative to cortisol. That wouldn't matter very much in peripheral tissues, but because corticosterone is disproportionately important to feedback, you'd get activation of the axis perhaps, and a disproportionate rise in cortisol, which wouldn't switch off the axis because it's less effective at feedback, but might lead to enhanced peripheral action, for example, in adipose, and indeed potentially in bone. So you might argue that an increase in this enzyme, if that mechanism applies, an increase in this enzyme would be associated with cortisol-driven obesity and a low corticosterone to cortisol ratio. And we now have evidence for that, which I'll go over quickly. So the evidence is that we've done some epidemiological studies measuring cortisol and corticosterone and relating it to cardiovascular risk factors. Now we know that the HPA axis has a sort of primary active drive that's increased in metabolic syndrome. And so unsurprisingly, at baseline, in the general population or in patients with type 2 diabetes, we actually find positive associations between both cortisol in orange and corticosterone in blue with features of metabolic syndrome. That might be because of a primary activity of the ACTH. But if we just look at the adrenal and look for this concept of variations in CYP17 activity, the way to do that is that we gave a few hundred people dexamethasone to suppress ACTH, and then we stimulated their adrenal with tetracycline or synacthin. And here you now see a completely different pattern where cortisol is positively associated with all of these cardiovascular risk factors, but corticosterone is inversely associated. So here's some evidence of a functional deficiency in 17-hydroxylase associated with metabolic syndrome. And we then went on and showed that that has a genetic basis. So it is known that there are genetic variants in CYP17A1, the gene that encodes 17-hydroxylase. They first attracted attention when they were identified as one of the first hits, one of the top loci in genome-wide association studies for hypertension. And it turns out that the genetic variants which predict higher blood pressure also predict lower enzyme activity with a shift of steroids in favor of corticosterone, and they're associated in population studies with lower body mass index. So if you turn that around, those variants which are associated with higher enzyme activity would be associated with lower blood pressure but higher BMI. And that's just what we found. So again, in population studies, in fact, we have more data now than this alone. So we've been able to replicate this in 3 different studies. The variants which are associated with lower corticosterone relative to cortisol, so relative corticosterone deficiency, those variants are indeed associated with obesity and with the corticosterone to cortisol ratio. So, again, that's not going to lead to any new therapies, but it does give some insight as to evidence that is accumulating that differences in your corticosterone to cortisol balance actually do affect function. Okay, so I promised that this would be an increasing order of interest and importance, so I'll move on to what I think is a somewhat more important deduction from this new physiology. And that is in relation to how we think of synthetic glucocorticoids. Now, of course, what I mean by that is anti-inflammatory therapies, and for as long as any of us can remember, we've been trying to develop anti-inflammatory glucocorticoids in a way that would be selective, so we could dial in, as they say, anti-inflammatory effects while dialing out metabolic effects. And the obsession of the field has been in doing that by manipulating ligand interactions with receptors and identifying selective receptor modulators and so on, so far largely unsuccessfully. It's a difficult challenge. But what if you could use the phenomenon of differential sensitivity to ABC transporters to achieve that? So let me lead you through this. I want you to imagine that there are essentially 3 different types of cell in your body. I could give you a 4th which doesn't have any ABC transporters, but just let's think about those 3 that do. So one type of cell only has ABCB1 and it doesn't have ABCC1. That would be in the brain. One type of cell only has ABCC1 and it doesn't have ABCB1. That would be in adipose tissue, muscle, and bone. And a lot of cells, including liver, kidney, and thymus, have both. And this would apply in a lot of inflammatory cells too. Now then imagine 3 steroid types. One type is only exported by ABCB1, that's red. One type in green is only exported by ABCC1, and the gray ones, maybe nothing happens to them. So if you predict what sort of active concentrations of those different classes of steroid will be present in those different types of cell, this is what you end up with. You'd say that the red ones would be less active in these cells, more active in these cells, and the converse would be true for the green ones because of these exporting transporters. Now, here's the list of the differential sensitivity of known steroids, glucocorticoids, to these transporters. And what it shows is that all of the synthetic glucocorticoids that we've created and used commonly in anti-inflammatory therapies, it turns out are like cortisol, or we also call that hydrocortisone, of course, in that they tend not to act so well on these sites, but have adverse effects mediated through adipose tissue. Unfortunately, there are no synthetic glucocorticoids which have these characteristics mimicking corticosterone. So one possible deduction from these studies is that we should go about and devise such steroids if we can, and try to target, therefore to target to desired effects, for example, in this sort of tissue over here, but avoid the undesired effects in peripheral tissues. So that brings me to the 3rd possibility of exploiting these observations, and that is, and this applies directly to the practice in pediatric endocrinology, that is the possibility that we could develop corticosterone as a novel therapeutic agent of itself, and indeed that it might be better than current glucocorticoid replacement. Because, of course, we all know that current glucocorticoid replacement is a hopeless, thankless task, really, and it is very difficult to manage. And we use either cortisol, that's hydrocortisone, or some of us use cortisone, which is then converted to cortisol. But whatever we do at the moment, we generally use cortisol. What would happen, and what I'm arguing is that cortisol would be less efficacious at central negative feedback, but would be more active in some of the, if you like, toxic tissues such as adipose. So what would happen if you used corticosteroid that might have the reverse effect? And of course, the obvious place where you might want to use that is in circumstances where you're trying to have a major effect on central negative feedback to suppress ACTH, whereas you're not actually motivated by delivering excess glucocorticoid replacement therapy to the periphery. And the circumstance in which you'd want to do that might be in congenital adrenal hyperplasia. So for this audience, this cartoon is largely redundant, but just in case there are any interlopers in the room who don't deal with CAH, let me remind you that it's caused most commonly by 21-hydroxylase deficiency. That blocks the production of glucocorticoids. That causes adrenal insufficiency. That failure of negative feedback causes ACTH excess, which drives precursor accumulation and thence drives adrenal androgen excess. And the goal of therapy is to suppress the adrenal androgens at the same time as replacing peripheral glucocorticoids. So it's really to have both actions. And the issue is how you balance between the two. And we know that we're not doing a good job, and I speak from the adult literature, so I'm one of the members of the group that Richard Ross brought together called the UK CHASE study, which accumulated a few hundred adult patients with CAH. And what we demonstrated, which is entirely consistent with the pediatric literature, is that if you give a dose of glucocorticoid, as you increase the dose here, if you give a dose that is sufficient to suppress the androgens, you always get toxicity. You most commonly manifest as hypertension and obesity. So we had the idea that we should see whether we could show that corticosterone would avoid some of that toxicity while at the same time being equally efficacious for suppressing ACTH. I can only show you at the moment preliminary data from this study, which we planned an interim analysis on, although we've done no statistics for it. So this is a study of CAH adults with 21-hydroxylase deficiency who are randomized in a crossover design to be infused with corticosterone or hydrocortisone in the same sort of stepwise program as I showed you before, with lots of metabolic measurements. The intention was to reach the concentrations in the black line of 400 and 800 nanomole per liter, and that's exactly what we did. For the green line, that's corticosterone infusion, so we achieved our goal. For cortisol, where we were infusing hydrocortisone, surprisingly, we messed up, really. We achieved lower concentrations of cortisol, and the reasons for that are obscure. It must mean that the clearance of cortisol is exaggerated in those patients, although we didn't predict that. So that's another interesting question, is why patients with CAH might have a different metabolism of cortisol. That's for another day. But let me just show that what we've shown so far is that corticosterone is indeed efficacious. It will suppress ACTH, it will suppress adrenal androgens, and that's reassuring in this preliminary analysis. But the other really interesting thing about this preliminary analysis is that it suggests that even though cortisol was present at lower concentrations than corticosterone, it was cortisol that had the adverse effects on hyperinsulinemia and to some degree on glucose. So we're really excited about these data, but of course I'll report back more formally when we've got a complete analysis to show. And for those of you who are photographing this, I wouldn't keep it for posterity. So I think I'm going to draw to a close now by saying that I hope what I've persuaded you is that it is one thing to think about the HPA axis on its own, and it's quite another to think about the complexity of the determinants of tissue-specific responses to glucocorticoids. And there's one final clinical message from this, I think, which is that this complexity is part of the reason why measuring blood levels of hydrocortisone or cortisol during glucocorticoid replacement therapy is probably a waste of time. In fact, I think it is a waste of time. What you really want to know is what's happening in the tissues, which is highly variable. So a lot of these mechanisms will change with time, with what you've just eaten for breakfast, with how much you've got an inflammatory condition at the time, and so on. So the one parting shot to this community was to illustrate that we're on the hunt for ways of measuring those tissue glucocorticoid actions in some sort of cumulative way. And a group of us, including particularly Gudmundur Johansson in Gothenburg and ourselves in Edinburgh, have been doing some systematic studies of looking for hypothesis-free biomarkers. Gudmundur has some interesting information on microRNAs, and our own work has been focused on small molecule metabolites in the blood. And from the CHASE study group, we took 117 patients from whom we had samples and analyzed a metabolome screen, which was able, I won't go through the details, but it was able to distinguish the dose of glucocorticoids. And then using a combination of 7 metabolites, we were able to divide people into those with supraphysiological or subphysiological replacement therapies. And that had high predictive value in this ROC analysis. So we're now actually very interested in running these groups of metabolites on any samples that people have, where we might have a good handle on how much glucocorticoid exposure there has been, with the goal that this would be a means of titrating glucocorticoid exposure in individual patients, which might be helpful. And there are other indications, such as the diagnosis of Cushing's or the prediction of adrenal insufficiency on those taking anti-inflammatory therapy, for example. So with that, I'll draw to a close. I'd like to acknowledge the CHASE collaborators. This was chaired by Richard Ross. And to acknowledge people who I've worked with over many years in the Edinburgh group, and I won't name all of them through lack of time, and also some colleagues far and wide who've contributed, particularly the genetic and the epidemiological studies. Thanks very much for your attention.